Good morning, everyone. Today, inspired by Brian and a very, very powerful presentation. Thank you, Brian. I once more extend my hands to all of you and ask you to join me in this journey to understand, to get to know better this coronavirus pandemic that we're facing so that we can successfully emerge from it. You'll know me, so I won't dwell on this. Today we're going to talk about two separate topics that are in fact intertwined. One is the clinical course of this illness, what happens, when, where. It all starts with a cough. And I'm going to tell you a tale of 100. Someone coughs, 100 are infected. 30 of those 100 test negative. 70 test positive. Of those 70, 4 develop symptoms. 20 are hospitalized. Of the 20 that are hospitalized, 10 go to intensive care. 5 end up being intubated and placed on a ventilator. And of those 5, 2 will survive. And here's how it goes. You get infected, there's an incubation period, following which you may or may not develop symptoms. You go into quarantine, or if your symptoms are severe enough, you're hospitalized. You're hospitalized and you get very sick, you may have to go into intensive care and be placed on a ventilator. Those who are in quarantine may very well recover, the majority do. If you're on a ventilator, you may also recover. And of those who recover, practically all develop immunity. And we're going to talk about what that immunity means. Immunity occurs in greater than 95% of those who recover. And it can be cellular, B and T cells, macrophages, killer T cells, memory cells, or it can be humoral. And when we say humoral, we include cytokines, chemical mediators, the complement system, and antibodies. And we're going to talk a little bit more about antibodies today. An antibody is usually depicted as a Y-shaped entity. And at the top of that Y shape where you see antigen on both sides, that's where this antibody attaches to the virus. So on the virus cell, let's call it a cell, it's not really a living organism, but it's an entity, let's call it a cell. There are antigens, there are proteins on the surface of that cell. One of them we call the spike protein. And an antibody that we develop in reaction to the infection will seek out and will target this viral entity and will attach to the spike protein. And then it will signal and attract other cells of the immune system to help it destroy this virus cell. And that's an artist's depiction of how this happens. You have the antibodies floating around in the blood, in the lymph, in the serum, and they come close to the virus cell that has these spikes, the spike protein coming out, and it attaches to that spike protein, and that's how we start to destroy, to attack, to win over this virus. Antibodies, and you're hearing a lot nowadays about IgM and IgG, means immunoglobulin M and immunoglobulin G antibodies. These are two kinds of antibodies. The M are the first to appear. They are shorter lasting, whereas the IgG appear a little bit later. They're longer lasting and confer immunity. They're the ones that in the long run make you immune. Both of them have been shown in the laboratory to be neutralizing. They neutralize the virus They block attachment and prevent penetration of the host cell. They interfere with uncoating of the virus inside of the host cell. Over time, as you see in this graph, over many days, first the antigen, the virus, appears in our system. And then we produce the IgM antibodies, the first one that we produce, but it's shorter lasting. So it goes away over a number of days, whereas the IgG starts a little bit later, but it lasts longer. We don't know exactly how long it lasts, but when we think about other viral illnesses that are similar to this one, they can last up to 1 or 2 years. And of course, we're hoping, we don't have that experience yet, we don't have the data, but we're hoping that this kind of immunity will last perhaps 1 or 2 years also. Now, we still need to elucidate, because we're learning every day. This is a stepwise process that we're undergoing. Remember, we started from 0. We're learning every day, and we need to find out more about the quantity of antibodies that we're producing. Is it sufficient? How much? How long does it last? What is the efficacy of these antibodies? We suspect that it'll be neutralizing because we have laboratory information that so indicates that they will persist, hopefully 1 or 2 years. And not only that, but that we will be creating memory, that our B and T cells, and there are memory B and T cells, will continue to exist within us, and should they be faced again with the virus at some point in time, they will remember. They will remember this virus, and they will produce more and more antibodies to combat it. Let's talk now a little bit about the tests that we use and what they mean. First of all, there are 2 kinds of tests. The tests for the virus that are called RT-PCR because of the technology that's used, and the test for the antibodies that are called in general serology testing. And everybody's now becoming more and more familiar with swabs. We used to call them Q-tips. We don't anymore. We now call them swabs, because these are the things that are inserted into your nose and all the way back into the nasopharynx, so that the technician can take a sample from all the way back in your throat and test for the virus. And here's the virus cell, a cell infected with the virus, and all of these yellow dots are virus particles. So you see that there are hundreds upon hundreds of those cells, which is why it's relatively easy in most cases to obtain a sample from the back of your throat. The test for the virus is called real-time reverse transcriptase polymerase chain reaction. And just like it's difficult to pronounce, it's a mouthful, RT-PCR is a complex, difficult to perform test. And here's what happens. Here's the virus, and you see all of these spike proteins coming out from the surface of the virus. Here you see them again. This is a cutout. And what you see is that there's an envelope all around the virus. And then inside that envelope is a piece of genetic material that we call RNA, ribonucleic acid. And that RNA is actually what we test for. Okay, you can test in anyone, and the timing can be before, during, or after that person develops symptoms. The sample is taken from the nasopharynx, as you have seen. That's the analysis. And there are few false positives. There are few false positives, and that's important. But there are about 30% false negatives. So 100% get the test, and in 30% of those, you'll get false negatives. They may be positive, but the test doesn't indicate that because it's just not sensitive enough. And when you do tests of this nature, you always look at sensitivity, linearity, reproducibility, ruggedness, and the limit of detection. Those are the characteristics that you want to have information on in order to determine if this is a good, suitable test or not. And unfortunately, on the tests that we are doing, highly technical and complex as they are, or perhaps because they are highly technical and complex, we don't have a lot of this information. Linearity, the tests are not quantitative. They do not tell you how much virus you have. They just tell you yes or no, you have it or you don't. And that depends on the limit of detection. And the best of the tests that we have available today, and I've looked at over 15 different RT-PCR tests that are today available from different companies, most of them in China. The limit of detection is 200 copies per ml. That is pretty good, but most of these tests are not that good. They're 500, 1,000 or more copies per ml, and you don't know which one you're getting. So this is just a photo of someone performing one of these tests, and I just want to emphasize how complex these tests are. They're time-consuming. Person has to be fully suited up because they're dealing with the virus, so they don't want to get the virus, and they don't want at the same time to contaminate the test. Contamination is easy to do when you're doing with genetic material. Limit of detection, let's make sure that we understand this term because we'll come back to it again and again. The limit of detection is the minimal amount of the virus or antibodies that needs to be present for a test to be positive. Now, the interpretation of the test can be negative or positive. If it's negative, it means that the person was never infected or was infected, but the infection has cleared and it's no longer present. Or it may be a false negative. As I said, 30% are false negatives. If it's positive, if the test is positive, it means that the virus is present and that that person is infected. Let's switch now and look at the second test, the second type of test, okay? Two separate tests, one for the virus. We're now going to talk about one for the antibody. Again, anyone can have this test, and the timing will be before you've had the infection, during or after you've developed symptoms. In this case, the sample is blood, plasma, or serum. And the analysis technically is different. It's called ELISA, or there are other methodologies. Enzyme-linked immunosorbent assay, another mouthful. Let's just call it ELISA. And there are others that are being developed because ELISA is also technically not as difficult as RT-PCR, but still difficult. And we need some that are simpler and faster. Again, this test is very specific to the antibodies for the virus. So there are few false positives. And in this case, there are also few false negatives. You either have the antibodies or you don't have them, and the tests are very sensitive and specific. As to linearity, again, we don't know the quantity. The test doesn't tell you you have a milligram, a nanogram, a picogram, a ton of antibody. It doesn't tell you. It tells you you have IgG and IgM antibodies or one of the two or none, but it doesn't tell us how much. So they're not quantitative. Reproducibility and ruggedness have not been reported. Let's talk about interpretation. But first, let me show you how the sample is taken. It's pretty simple. You hang your arm outside of your car at the drive-up station. Someone gives you a finger stick in one of your fingers, takes a couple of drops of blood, and you have given a sample. That's it, very simple. And there are a number of kits. This one, just as an example, made by Biomedomics Corporation, but there are many others, including Abbott, for example, that have such tests. Again, pinprick, fingertip, drops of blood onto this plaque, and then you put some reagent on it, and then you just observe it. And if you have IgG antibodies, the control will light up and the IgG band will show up, but you don't have IgM in this particular case, so it doesn't light up. Okay, so this particular test has been positive for IgG antibodies. And you know that the test is working because the control lit up. So it's working. So here are a variety of ways that this test can turn out. The test can be negative for antibodies, where only the control, C up here, lights up. Or it can be IgM positive, where the control and the IgM light up. Or it can be IgG positive, where both of these lines light up, or IgG and IgM positive in addition to the control. Okay, I'm over my time, so I'm going to go fast now. The clinical significance, I won't go into this, but let me just say that the good news, again, is that vaccines are underway. Here in San Diego, Inovio Corporation started the clinical trials. They placed their first patient on study on April the 6th. There are studies ongoing in the UK and in other countries, and we will, hopefully as soon as possible, have vaccines. And the importance of vaccines is that vaccines give you immunity before the fact, before you develop the disease. They make you immune to the disease. Whereas the other way that you can get antibodies is actually having the disease, and that's after the fact. The other important thing to mention is that therapeutic agents are also being evaluated, will be produced, and will be able to better combat this epidemic. So I'm going to stop there. Thank you very much.